first case, this is case of the week, case of the month, probably. So this is the initial presentation. So the guy is basically alcohol abuse, 55, already in the ICU, presumably with pancreatitis. And we get a phone call. I was on the procedure rotation, and we get a phone call to drain a cyst. And so this is his imaging from an outside institution.
Can you make it a little bit bigger? Like on the bottom right, you can make that plus sign a little bit bigger.
Let me just see if I can. Yeah.
Yes. Oh, yeah, that's good.
Okay. All right, so some axials. This is with contrast. I'm going to show you the coronal. Okay, so same scan. I'll go back to the axials, and then we can start, maybe people can start saying what they're seeing, what's abnormal. This is many things going on here, so we can maybe go one by one. Artie, do you want to read me what people are saying?
Yeah, so Kedar says portal venous clot. Tammy also says portal venous thrombosis.
Okay.
I'm wondering if that is a pseudocyst that is ruptured into the portal vein.
Mm-hmm. Okay, perfect. Anything else on the axials that's jumping out at you, like the bottom set of images here?
Definitely like cavernous transformation, and then
correct.
That bottom right image looks a little funny. Like, is there a mass in the pancreas or?
Right. Okay, so correct. The abnormality is in the portal vasculature. And we have what looks like cavernous transformation, which is showed nicely here. I'm going to go back to the coronal here. And you can see again here is a ton of vasculature that shouldn't be there. That's what we call cavernous transformation of the portal vein. And so people said thrombus. Okay, perfect. That was one of the thoughts that we had. I'll point your attention to these sort of bright areas, for example, right here in the right portal. And then there's some high density material layering. So this was just a single phase. And so we said, listen, we don't know what this is. We're gonna perform our own imaging, multi-phase imaging, non-con arterial portal venous. And so we ended up re-imaging him at BI. So I'm gonna show you, this is the arterial phase. So same thing. We see this structure that's essentially highly expanding the portal vasculature that seems to be associated with the pancreas. You can see that it's doing the same thing. This is the splenic vein. Can you see my arrow?
Yes.
Okay, and then we have this high density material again, right here layering, here dependently, here not dependently. And it's difficult to compare if you're not doing it yourself, but the structure has expanded between this scan and this scan. So it's evolving, and you can see now we have a little bit of buildup, which we didn't have on that initial scan. This is the non-con images. Okay, and this is the portal venous phase. I'm going to show you a couple more things here. Again, we see cavernous transformation. We see this high density material. This is sort of in the vicinity of the GDA. And you can see that there's multiple structures like this. So this is in the head of the pancreas. Show you the coronal again. This is a portal venous phase, multiple structures. Okay, right, so left portal vein, right portal vein. And
it doesn't really look like active extrav or pseudoaneurysm.
No, we did not see any active extrav, no. So that was the point. We wanted to see if they're actively bleeding because we saw this high density material. We were wondering if there's blood products in there. And one more thing I want to show you. Sorry, there's lots to see in this case, so I'm just going to show it just so it's easier. The main pancreatic duct, like this is a nice example here, it wasn't normal. It was dilated. I'll show you on the coronals if I have a nice image too. So it wasn't a normal size, it was dilated. We ended up doing an ultrasound the same day. We couldn't sample any normal flow in the portal vasculature, whether in the liver or outside of the liver. And as you would expect, because we could see already that there was cavernous transformation, which tells us it's some sort of long-standing obstructive process. We saw no flow in this structure that is following the path of the portal vasculature. So we were presuming that this was cystic in nature. Okay.
I have one comment there. You said cavernous transformation means that it's a long-standing structure?
That there's some chronicity to the obstruction.
Yeah, but I think that it can develop because you have like this peri-portal vascular supply that's already there. I think it can happen acutely too. Like you can even get it within 12 to 24 hours.
Really? Okay. Good to know. I was always under the impression that that indicated that there's some level of didn't happen acutely. But I'm going to look that up. And anyone feel free to comment on that if you have experience with this. So the point is here. So again, we didn't see any flow in this structure, and we saw this debris, which we thought was what was bright or on the non-con. So maybe some blood degradation products. We didn't see any extrav on the CTA. And so we didn't know what this was, basically. The point was to see, if we stick a needle into this, are we going to make this patient bleed? And so
Rupa and Gitanjali also are guessing pseudocyst decompressing into the vein.
Right. So IR ended up taking him to the suite, and what they ended up doing is they wanted to attempt to cannulate the portal vein or any portal vasculature, and to see whether there's a communication between the portal vasculature and the cystic structure, presumably a pseudocyst. They weren't able to there wasn't any portal vasculature to be seen. So what they ended up doing was going the other way. So they put a needle into the cyst, they aspirated it, sent that for cultures, sent that for amylase, and we'll chat about that in a second. And they attempted to inject to see if there was any opacification of the vasculature, and there wasn't. So basically, we just left a catheter in, aspirated it. It didn't grow any bugs, but it did show that there was 19,000 of amylase. And so that tells us that there is pancreatic juices in this structure. So any thoughts about how that might have ended up in that location and why it would have presented this way? There's a specific entity, which is the working diagnosis here. Any thoughts? Super rare. Artie, you said dissecting pseudocyst, correct? You said that?
Yeah, I've seen a couple of cases of this, but I didn't know what caused it. I guess it was just, I thought pancreatitis, pseudocyst, and then it eroded into the portal vein.
Right. So there's an entity called, I'm going to show you. Well, actually, let me just show you before we go on. There's a lot of images here. This is after drainage, and you can see that we decompressed basically the cystic structure. There's no normal opacification of the portal vasculature. Again, we see this cavernous transformation. And one thing to notice here is that the main pancreatic duct is no longer dilated, which it was on the pre-drainage images. So this is the working diagnosis here, is a pancreatic duct portal vein fistula. Super rare. It's a rare complication of chronic or recurrent pancreatitis, and mostly described in the context of alcohol abuse. And there has been a couple of cases of trauma pancreatic surgery with the same outcome. Only 18 cases in the literature, so extremely rare. The thought is that you have a disruption of the pancreatic duct. It's typically in the context of pseudocyst formation. So the pancreatic enzymes in the pseudocyst will erode into the portal vein wall and cause thrombus. And eventually, once this thrombus liquefies, you get opacification, or the portal vein fills with the pancreatic secretions. Challenging diagnosis, and so you need a combination of cross-sectional imaging. You need percutaneous transhepatic portography, which we attempted, but couldn't because we didn't have any portal vasculature to cannulate, and ERCP. And so feared complications, of course, hemorrhage, and the other thing that they fear is diffuse liquefactive necrosis, basically necrosis of the liver from pancreatic juices. This is some images from the literature. This is a percutaneous transhepatic portography. So here we have, basically they cannulated the portal vein. And you can see that with opacification of the portal vein, there's this communication with a pseudocyst. And then an example of what an ERCP may look like in these patients. So here you have the main pancreatic duct. You can see that it's abnormally dilated upstream from this communication to this disruption, and that there is abnormal dye going into a pseudocyst in this location. So again, treatment depends on the patient, depends at what stage they present. They're typically drainage, stenting, glue embolization. So extremely rare. I know there was a lot of images. Any questions? Our guy is currently has ARDS, so he didn't get ERCP yet. And as I said, we attempted the portography, but we didn't have any, probably from long-standing obstruction, we didn't have any portal vein to cannulate. So we tried to go the other way, and we weren't able to show the communication. But
that's pretty cool, though. Like basically, they put a drain in the portal vein.
Right.
Actually, Conrad Mortel, your former pathologist, showed me a case of this, and I don't know if it's this exact patient because they were from BI, I think, but he showed it on an MRI, MRCP.
Yeah.
you see this like big, T2 hyperintense branching structure, and you might mistake it for a dilated bile duct, but it's actually the portal vein filled with pancreatic juices.
Yeah. Any questions, anyone? Again, if he eventually gets in the RCPL, I can show again what that shows, but he needs imaging of his pancreatic duct, MRCP, RCP. But this is the working diagnosis. Pretty cool, pretty rare.